joining in for the next conversation are these panelists. I think quickly, can you show the slides? Dr. Anand Jayasekharan, who is the Consultant Department of Hemato-Oncology, National University Cancer Institute, Singapore, Principal Investigator and Facility Head, Cancer Science Institute, National University of Singapore. Dr. Anand will hear about you more. Dr. Asha Nayak, she is trained in India, KMC Manipal, and now moved to UK. She was a pediatrician, now practicing as a general physician, GP, at Swanscombe Health Centre in Kent. Next slide. And Dr. Shweta Singhal, she is a neuro-ophthalmologist at Singapore National Eye Centre. Also holds additional research and teaching appointments, including assistant professor of ophthalmology with Duke NUS Medical School and clinical lecturer with Young Lu Lin School of Medicine, National University of Singapore. She's a clinical scientist and also runs a lab-based stem cell research program. So welcome, Dr. Shweta, and of course, Dr. Nikhil Aggarwal from Gurgaon. He's a practicing general physician, but he is also a two-time blood cancer survivor. And we would like to hear from you, Dr. Nikhil Aggarwal, from both doctors and patients' perspective. Dr. Ruchira was very keen to continue conversation with you. I hope she's around. So I think we can start with what the previous panelists were discussing about, how well you know your patients and how you self-preserve. So we can, and then we move on to shared decision making and the medical uncertainties we tackle in our practices and how to deal with that. So starting with Dr. Shweta.
Hi.
Hey.
Thanks, Veena, and nice to see everybody.
I will maybe let you all interact with each other, because I think now you know a little bit about each other. Yeah. You can start the conversation about medical uncertainty. Then I would like Dr. Asha to maybe join in. Yeah. And Dr. Anand, please be there because we would like
Veena?
to hear you.
Yeah, hi, Veena.
Hi.
I'm just joining on Shailen's. Is it all right?
It's perfect.
Yeah,
yes.
Thank you. Thank you.
Yes, so Shweta.
Yeah, so it was nice to listen to some of the comments from the previous panel as well, because again, that's very close to our heart in terms of doing right by our patients, and also in the context of medical uncertainty really helps a lot to actually know where your patients are coming from when you have maybe limited options or when you have difficult decisions to make and you want to see where they're coming from. So like we had been talking about the other day, in situations, so as a practicing neuro-ophthalmologist, many situations where my patients are sometimes actually, they are not even sure what's wrong with them, or they're not sure why they're with me, because all patients in terms of an eye condition understand is that their vision is not very good. And sometimes they've come to terms with it. Sometimes they know that it's not that good, but they can still do everything that's necessary for their lifestyle, for their activities of daily living. And the extents that we go to kind of try and identify why that one small neurological deficit that they're having exists, and is there something more sinister going on that's life-threatening or sight-threatening that we need to chase. And to them, it seems like we are doing a lot for very little. And I think in that situation, particularly when we chase all this and we don't get any answers, and then we have to speak with them saying, why did we do all this? And why, how are we going to make a decision on what to do next? And they're wondering, well, I have no problems. I'm fine. I have a little bit of blurring of vision in this instance, but I'm not quite sure why I'm here. So that actually is, strangely enough, happens a lot in Singapore, and it's very surprising, but I think it's because a lot of the time we don't listen to where the patient is coming from. And we go by, again, that mechanical, I must do steps 1 to 10, and I must find out if all this is okay. And if it's not, I need to chase it, irrespective of how that influences the patient. That I find quite tricky in a lot of the situations. So starting off in any situation when these patients are referred to me, the first question is really, how are you doing in terms of, do you know why you're here? Is this something that's troubling you a lot? And then we can go from there. We can make the decision from there. How much do I need to chase? This is going to cost this much money, and this is going to result in this kind of outcome. But do you really want any of this? So, I mean, this is kind of a little bit specific to my particular situation, but I do see that happens quite a bit, even with, and particularly when I work with my younger residents. Again, when they come to me to ask me, I'm seeing this abnormality on this test. What should I do? And then when we go back to say, but what does the patient complain of? Many times they haven't checked. They haven't asked the patient, so that basic, why are you here? What is it that's troubling you? And does it really matter that this test is not 100% normal in their context? So I think that was what struck me in terms of the getting to know your patient. And I think that segues nicely into how you deal with situations when you're uncertain as well, because then, when you know where the patient is coming from, sometimes even if you don't know what's going on, you can help them. Even if you haven't gotten to the bottom of the problem, you can still help them with whatever it is that's troubling them, because it may not be the same problem that you're trying to solve as the clinician in the situation. And so therefore, when it comes to, what we were talking about the other day about humility and saying to the patient, I don't know, I feel like it becomes easier to say that as long as you're addressing their problems. Sometimes they don't really care that you don't know X, Y, and Z, as long as you know A, B, and C that's relevant to them. So yeah, that's kind of where I was coming from when we first talked about the difficulty in sharing with our patients that we don't know what's going on. And of course, the other day, Dr. Nikhil pointed out very astutely that doesn't work the same way in different demographics. So that comes back one more time to knowing your patient well, because if they're there because they want that particular answer, then they're not going to accept that you don't know. And then it becomes a lot harder to explain why you've spent a lot of time and money trying to chase something that you haven't been able to give them an answer to.
Just to set the context again, we have been referring to a previous discussion we all had, and the discussion basically focuses on a very important point in medicine, which actually emphasizes also the role of medical humility. There are lots of diseases, specifically in the field of neuro-ophthalmology, as Dr. Shweta is saying, but also in many other fields where we do not always understand what is wrong with the patient. Even if we understand what is wrong, we may not be able to do much about it. So those are situations. I don't think we have the arrogance of thinking that we are going to treat everyone and diagnose everyone. That's actually a very small percentage. So starting from there, how do we say that? And I think what I heard, Dr. Shweta, is rather than so what clinicians want for the patient and what the patients want for themselves may not always be in sync. So unless you know what they want,
that's right.
There may be an asynchrony. Dr. Asha, you want to take up from that? And Dr. Anand, please pitch in. I was hoping that you
sure, I'm happy to help moderate. So please, yeah, Dr. Asha, your thoughts on situations that are easy to say I don't know in your practice and difficult to say I don't know in your practice.
Yeah, like currently I'm working as a general practitioner here. So the way in the UK it works is the patients first come to the general practitioner and we try and manage what we can. And, we do the basic investigation, we try and treat what we can. And when we can't, then the secondary care, the hospital referral happens. So we are like the gatekeepers. So everyone comes to us. And then the next level is the hospital. So we are always dealing with uncertainties because, they come with all these different symptoms. If they are really unwell, then they will go to the emergency care. Otherwise, they will come with these symptoms. And the problem sometimes can be they will come with a multitude of symptoms. I've got this, I've got that. And for us, we have to try and put it all together. And because we are general practitioners, we kind of, the whole family will be registered with us. So you kind of get to know the whole family, the parents, the children, the grandparents. So then it becomes, what shall I say? You develop a relationship with them, a doctor-patient relationship, which becomes easy because, when you're dealing with symptoms or explaining symptoms, you have the patient saying, yes, this is how it works, let us, I understand this doctor, or I understand this family, how much I can share at one given time, how much I should withhold now. The wait and watch policy, it becomes a bit easier if you know your patients as a general practitioner. And I think once we refer to the hospital, sometimes there it might be difficult because you'll have different doctors seeing the same patient at different time. So the continuity is lost, which I think in general practice, the continuity is there. So it gives us the time to understand the patient, and then we can slowly give the information little by little, and take it, see that they really understand what we are trying to say, what the investigations are planned, and then take it from there. Probably it's a bit easier here because it is government funded, so it's free at use. So the downside of that is patients believe that they can have whatever they want. So it's just the doctor who is not doing the tests, because the tests are there, and you should be allowed to do it. But the end of the thing, there is a limited amount of money, and you have to manage the whole population. So here again the uncertainty comes. Should I really do that chest X-ray? Should I really do those blood tests? Can I manage clinically initially? So those are the difficult decisions. But yeah, we try and do that.
So before I perhaps ask Dr. Nichols in perspective as a doctor practicing in India, one follow-on question there is, there must be some situations that patients, you mentioned, they come in with an expectation that all these things can be done. But
Yeah.
when are the times that they are okay for you to say, I don't know what's going on, and I will be okay to go home without having these things? And when are the times when you find that really hard to say?
I think when they come with a short history, a lot of the time they're okay if we say that, okay, you come with a backache. Quite likely it's a muscular pain. So let us try, the painkillers, the cold compress, and maybe a bit of physio. They are okay with that. The problem comes when it becomes a bit more chronic and long-standing. And then they will say, right, I want a scan done, I want a referral to the orthopedics. And then it becomes, we have pathways here. So unless the patient fits in the pathway, we can't refer further on. And that is where it becomes difficult. They're like, how sure are you that what your diagnosis is right? They challenge us. And it's almost like, I'm having the money and I'm not giving it to them. It can become a bit difficult. But yes, if you have built a rapport in the initial period, then they are willing to say, like, yes, let us wait for another few weeks, or let us do this, and then we can get what you want. That becomes a bit smooth. But yeah, that is where the challenge is. When they want the tests that the doctor feels they don't need it, that is the challenging bit.
So the longer their problem that they want an answer to remains unanswered, the
Yes.
less patient they become with being told that I don't know.
And I think mainly because of pain, because when I was training in India, I didn't see so much. Now all these pain syndromes, and I think we are learning about these new syndromes as well. I wasn't aware of so many things which were there that now we talk about the the Ehlers-Danlos and things like that, the fibromyalgia, we didn't learn that much when we were in medical school. So for the patient, it's a real symptom. The patient is really crippled. Their day-to-day life is affected. Their mental health is affected. But when the patient in front of you on examination is fine, and so the first thing to say is, I understand you. I know you have a problem. We will try and see how much we can do. We might not be able to cure you. I might not be able to give you a diagnosis now. But, let us work as a team. That's where the shared decision-making comes. Right. And then I ask them, okay, what do you want to try? Because a lot of them would have done research on their own. Then if it seems reasonable, I'm like, okay, let's try that. So then suddenly they feel this doctor is on my side. And then I think it becomes easy. Once the patient feels the doctor is on my side, then I think they're willing to accept when the doctor says, put up your hand and say, I don't know.
Wonderful. And Dr. Nikhil, just to follow up on that in the Indian perspective, a busy practice in a big metropolis, a lot more patients, I'm sure, than what, us in Singapore or the UK tend to see. How do you deal with this issue of when you don't know? I think you have to unmute yourself.
Yeah. Good evening, everyone. I'm Dr. Nikhil, and I am a general physician and a two-time blood cancer survivor. So I have my views from both the perspectives, and hopefully I will be able to add some value to the discussion. So yeah, as a general physician, my area is limited, and so many times people come like they ask something for their kids, and I am very much, I would say, comfortable telling them, okay, this is not my area. You should go to a pediatrician. I can give you basic advice, but yes, if it comes to medicines and dosing and all the things, so it is not good for me or for your child. So that is very common. Then again, like during COVID, so many times it happened that a patient was admitted in the ICU or in the ward, and their relatives were not able to meet them. They were not even able to communicate to the treating teams. So that was a situation when I used to get a lot of queries from people. Okay, my brother or my father is in the ICU and he is not recovering, and we are not even aware of what is going on. So they want me, like they have little bit of information, some reports they will have, some scan they will have, then they would want me to tell is the treatment they are getting is correct or not, and what are the prognosis. So that time I had to limit myself because I don't know the whole situation, what is going there in the ICU with the patient, and with the limited information, and as such, I don't even have that experience of treating ICU patients. So those things keep coming up in routine also, but in COVID times, they were quite too much. Then again, there is another situation because of me being a doctor and a cancer survivor. I am in a lot of online support groups for the cancer patients. There, people ask me a lot because they think, okay, he is a doctor and he has gone through all these things. So then, when they get diagnosis, the uh, treatment is something very difficult. There are lots of side effects and lots of misconceptions and lots of fears. So people want me to tell them again about the treatment options, what else can be done, what else could have been done, then the prognosis, and uh, when somebody gets relapsed, that time their queries are too much high because they are in the belief that, okay, now we have fought over the cancer and it's done. But then they are like, okay, we got the proper treatment, how it happened. So that time I have to limit myself. Okay, yes, I am a doctor, but I am a physician and I don't know this. So that is very common. Then
Wonderful.
Now up to you. Maybe I can ask you the next question.
Yes, please, go ahead.
Yes. So tell us about yourself and the role of shared decision making in your setup. How do you do it? What are the challenges? This is a very hyped term nowadays.
Yeah,
So the hype around it and the fallacies there. I mean, there are things which we can.
Yeah. So thank you, Dr. Bina, for inviting me here. So I'm a medical oncologist, and as in medical oncology or in any form of cancer care, there are, number one, many uncertainties. There are often a lot of complex emotions. Cancer is considered a sort of bad word by the layperson for the most part, and at the same time, there are lots of new things that are coming up every day for treatment. So how do we bring all of that together when you're sitting in front of one person? So I think the question of the previous conversation, which I had the privilege of listening to, about how well do you know the person, followed by when do you want to say no, I don't know, followed by what should we do together. I think those three kind of flow very nicely from one to the other, and we see that on a sort of routine basis in our practice. So I can certainly say that I fully agree with the concept of knowing the person. It's the easiest way is just I think of it a bit like when you meet somebody at a party, you ask them some questions about themselves. And sometimes even those general questions, as you're examining the patient, tends to spark off a little bit of conversation between you and them. And you come up with these, he likes playing tennis, he likes doing these sort of things. And it creates, a level of rapport that you understand that person a little better. And I fully agree with Dr. Sunita, I believe it was, who said open-ended questions that really start off, what is this actually doing to you? And then I think we can go into those. It's for us, it's not so much often an issue of we don't know what is wrong. We usually know what is wrong, but we don't know what we can do to fix it. And that also, very often we have to put our hands up and say, well, I'm afraid we don't really have good answers for you, and that's where this shared decision making comes, because you say, okay, which bits are you willing to sort of accept that we address first, or we try to address in an unusual way, or we try to come up with some workaround solution for it. And those are so the hype term there is really just, you having a conversation with somebody and saying, okay, there's only some stuff that I can do, but what shall we do together about this? So I think that's the sort of summary, I would say, of this point of shared decision making. But therein lies the other topic that we brought up at this forum, which was collusion. And that becomes very hard then, because you can't do a lot of these things if the person on the other end does not have all the information that is available for them to be able to make these decisions in their own best interest or for themselves. And so before I perhaps continue this monologue too much longer, I'll stop and maybe ask the others what sort of scenarios of collusion have they seen in their life, and perhaps Dr. Nikhil in particular, when you saw it on the other end, you're a part of patient groups, you're part of relative groups, things like that. So I think how what are the scenarios where families try not to tell the patient too much, and how does that challenge you in your practice, and particularly in times of uncertainty? So Shweta, maybe we start with you.
Actually don't see that much collusion. Because most of the time my patients come in with family members who are essentially just trying to make them more comfortable, and it's not really, the decision is not that hard in the situations that I encounter. But the few instances where I do see a little bit of collusion is when the patient has some sort of altered mental status, early Alzheimer's, a little bit of dementia. And then in those situations, there are some caretakers who are quite overbearing and who will want to be the person conveying the information to the doctor. and the person making the decision, even when the patient does have certain capacity to convey what troubles them and what doesn't trouble them. And so I think in those instances, in the beginning, I've had a few sort of, what's the word for it? Clashes, shall we say, with the family member, where I've tried to say, but she seems to understand what's going on. And when I check her, she's able to see fairly well. So, and then they would be like, no, you don't understand. She's not like this at home, and she has mood swings, and sometimes she's really difficult to deal with. And so then it becomes a matter of not just dealing with the problem of the patient, but also listening to the caregiver and their concerns, because clearly in that situation, the caregiver is actually more stressed than the patient themselves is. So I guess for me, that's kind of the closest it has come to when the caregiver says, I want this and this done. And I've said, well, from her point of view, I think this is sufficient, but let's see how we can help you. Make appointments easier, put things together so they don't have to come back too many times, get medication delivered, that sort of stuff. So I think that would probably be my experience, usually not very common.
Yeah. And Dr. Asha, from the general practitioner's perspective, and then Dr. Nikhil from the Indian perspective.
I think here the thing in UK is the patient autonomy is a big thing here. And unless there is deemed that the patient has got no capacity, generally we as doctors tend to pay more attention to what the patient wants, and probably the exception would be the children, where again the parents will be making decisions for them. But the problem sometimes happens is, it's a multicultural society, the Britain, and then you have the ethnic minorities who carry the same thing. The Indians coming from India, they know better than their parents, the children feel. And same with the Afro-Caribbean families, the other ethnic minorities. They feel they know more, and the logic would be, my parent can't speak much English, but they probably understand. And we can try and get a translator and explain to the patient if they want to decide what they want to do. And the other thing here is when we are trying to get patients in care homes, we try to keep the patients in their own home as much as possible. But at some stage it becomes it's becoming difficult, even with the carers coming and going in long-term care. And I think being a GP, that is where I struggle the most, because the family is like, we can't cope. The patient is not eating, drinking much, is getting abusive to carers, doesn't want to go into care. Then how do you deal with that? And if the patient has capacity, it becomes very difficult to override. And here then the legal system comes in. So I think it's a bit different how it is in India or Asia compared to how it is probably in UK and US, I think. But sometimes you go along with the children as well, because I've had some, a 90-year-old diagnosed with cancer. And the daughter herself, who is about 70, says, please don't tell my mom, we're not going to do the treatment anyway. And then you're like, right, okay, we'll try and minimize it. So we do sit on gray areas for the sake of the family. But yeah, no, I think less conflict here coming to, explaining the diagnosis and things like that.
And Dr. Nikhil, I'm sure collusion is a common occurrence.
Yeah, it is.
Back home.
It is very common, and as Dr. Asha said about the patients who are deemed to be unfit to make the decisions, but here in India, I think family considers every patient as they are not capable of making their decisions, and they are not capable of taking the diagnosis, which is most often I find wrong. And whenever I talk to other patients, be it my patients or be it the other cancer patients who talk to me as a survivor, they actually want to know what is the diagnosis, what is going on, and even the side effects. So many times people say, okay, person has been diagnosed with cancer, so you don't tell them the side effects. When it will happen, then it will happen. But when they already know that these are the possibilities, they can be more comfortable instead of getting into a shock suddenly when the things come up, because usually the things come up. So for the diagnosis, for the treatment, for the side effects, for everything, I think the patient should be kept in the loop. Of course, as Dr. Asha said, there can be some gray areas where you have to be, I mean, again, Dr. Bina also said earlier about the porous boundaries. So there can be things which you may have to modify a bit. You can't be 100% direct to the patient. Give them time to absorb and again listen more and understand how much they can take. But they should be told. Even for the kids, in the previous panel, Dr. Ruchira, she told that whenever we tell the things to the kids, they are much better able to understand what's going on. And because see, ultimately here in India, what people try is they try to hide the things from the patient, but they can't hide because the thing comes up in their expression, in their behavior. And the concept is okay, cancer is a death sentence. So in everything that comes, and patient is also feeling things, they are getting the treatment. So they are in more worse situation when they are confused. They don't know what is happening, why everybody is behaving like that. So that is a bigger trauma, I guess, compared to telling them properly, hey, yeah, this is going on. And again, if we come to the treatment part also, the decision what a family wants can be very different from what the patient wants. And more so in the terminal patients. Okay, they might not want to take the treatment. They might want to spend time with their family at home, but family is in a confusion. I mean, many times I have seen this thing also, okay, the family, the caregivers, they also understand the treatment will do more harm to the patient in that stage, but they are hesitant to take that call to stop the treatment because they have kind of responsibility. They feel that, we have to keep trying for the patient. So those are a lot of things I see.
And I see Shweta has a question for you.
Actually, I had a question for the whole panel, and two things. Because the first was when Dr. Asha said how about the 90-year-old patient and the 70-year-old daughter who was like, let's just leave it. So, just to the whole panel, do you find collusion a little more acceptable when it's to not do too much for elderly patients? That's number one. And number two, maybe Dr. Nikhil can expand on that a little bit more. Is that you were saying how caregivers, irrespective of age, whether it's an elderly caregiver for a younger patient or a child of an elderly patient, there seems to be this feeling that once you've been diagnosed with a serious illness, you're no longer capable of making a decision for yourself. And as the caregiver, it is now the caregiver's responsibility to make all these decisions. And I don't know, is that the core behind why all this collusion happens in the first place? That the patient with the diagnosis is automatically removed of the capability of making the diagnosis. So Dr. Asha first, maybe, and then Dr. Nikhil, if you want.
Yeah. No, I think the way I look at it is, I would personally prefer to explain the diagnosis to the patient. Maybe in a, what shall I say, not probably the full extent, but broach it slowly and explain so that the patient understands. And when it is very elderly patient, more than say 90 or 90 over that, lot of the time the difficulty becomes because they are looked after by these their children or the caregivers who are struggling to come to the diagnosis themselves. So what I normally tend to do is give them a little bit of time for the family to absorb it, but I tell them, this needs to be communicated to the patient, because at the end of the day, the patient who is having the condition may want to live their life in a certain way, whatever days they have, months or whatever. They might have had different plans. They might want to put their will in place. They might want to do a lot of things. So I think age, yes, to some degree, we would say I would keep it as one of the reasons that we might make decisions like that. Otherwise, I strongly believe that the patient needs to know, no matter whether it's a young patient, even children. I feel you should come to their level and explain the diagnosis to their level. Even if it is a 10-year-old, you try and explain it in a simple way. Maybe not go the full extent, but a patient needs to know, and then they can and involve them in their treatment, because then you have better compliance. If you explain the diagnosis and why you're doing certain treatments, there will be better compliance, and then it will be a better shared decision making as well. That's how I feel. What do you feel, Nikhil?
Yeah, I feel a lot similar to what you said. And yes, again, the collision is there because of, as I mean, Dr. Shweta said exactly, people who get any diagnosis, they are deemed to be incapable of making the decisions. And along with that, there is another thought of protecting the patient. They are like, okay, he or she is going through already so much mentally and physically. So we don't want them to know about the things which can go wrong, and how to make the decision, all sorts of things. I mean, I again had a patient few days back. The patient was old, and his daughter was talking to me, and the patient was not ready to get the treatment because he had been through a lot, and he was like, okay, now I don't want the treatment. So his daughter wanted me to speak to him and uh, tell him the things which are not real, and to tell him that, okay, nothing will happen and everything will go good. You won't feel much, but the results will be great. So I told her, okay, first of all, I can't do that. Secondly, even if you approach somebody else to do that, that will be very wrong for your patient, for your father, because ultimately, when the treatment starts, he will have those side effects. And for the future, I mean, even the greatest doctor cannot say, okay, what will happen. So making him in that scenario is much worse, because again, as you said, they have something in mind how to live their life and what are their plans, because see, most of the people assume that they won't get any cancer or any disease and they won't die, so they are not living actually how they want to live presently before the diagnosis, I'm saying. So everybody has this set of list, okay, I will do this, I will do that when I get free from all my responsibilities. But they actually don't get to that point. So if a person knows that I have a limited time, be it again months or years, and my life has to be with this disease, so they are most likely to give priorities to those things. And if you don't tell them, they lose that chance only. So that is most very commonly seen here in India. And one more point I want to add. Just 2 days back, I had a patient. Uh, the lady, she had blood cancer, and they had to undergo the stem cell transplant. Her husband wanted her to get treatment at some other place. She wanted treatment at some other place, and the husband was trying to insist on her. But I told him, okay, unless the patient has confidence in the doctor and the team, the patient won't be comfortable, because they have undergone 4 cycles of chemo with a particular team, and the patient wants to continue treatment there itself, and that is again a good doctor and a good center. So if you suddenly take them to another center, so that won't be good for the patient. And again, if you feel there is some good reason for that, talk to the patient, make them aware, and let them make the final decision. Not, you should not make that decision. So these are some things.
Yeah. So one thing I in my practice I see a collusion a lot. Even though Singapore is a sort of so-called developed country, but a lot of typical Asian sort of mentalities still are prevalent. Now, I've kind of, and I'm sure most of you have realized as well, that collusion always comes from a place of love. it fundamentally starts off with them wanting to protect that other person. Then there's a second layer, which is power, which is about, I'm paying for this treatment. So therefore, I also should be part of this whole thing and trying to, decide what needs to be done. But I still think that the bigger component is the love component. And then trying to address that first, saying, look, we actually want the same thing. We want your mother or father to feel okay. But there are going to be some difficult challenges that are going to come up. And then what are we going to do at that point? So kind of preparing that road ahead, saying, okay, if they know, this will be easier. If they don't know, this will be what you're likely to face. And then the other thing, of course, is, sometimes patients actually don't want to know too many things. There are certain elderly patients who genuinely don't want to be bothered with a lot of detail. They will actually say, talk to my children. But at the same time, I think giving them an invitation to say, what do you want to know? What do you want to actually ask me about this? I find that as a simple tool to kind of, so I tell the family also, look, we don't have to go into details about this is stage 4 pancreatic cancer and, it has cells that metastasize to your brain and nonsense like that. But really, if they were to ask me what is wrong with me, you can say that, hey, there's something growing inside here and it's going to be difficult to remove and it may cause problem XYZ as we go along. And we'll see what we can do about it. But that type of, shall we say, open-ended permission for the patient to just say, okay, I'll ask these questions and I'll get an honest reply about it. That it's one way that we have used to tackle collusion over here. But that being said, not every patient and every family member will agree to these things. Often getting them to that space where they'll even agree to let us have that conversation sometimes can be challenging. I've had instances, particularly of sometimes very wealthy people who have their parents' best interest at heart, but feel, oh, he's not strong enough at this point. If we say this, they won't agree to treatment. I want you to do this my way. In my earlier years as an oncologist, I kind of went head to head with them in the first few conversations, and it always turned out badly. It never went well. You was like, no, this is the right thing to do. No, but you don't know my mother like I do. And so they say, okay, now why don't we put that conversation for later, and let's just say, first let me try to get to know your mother a little bit more, and then we'll try and see what we need to do to address this particular problem. So yeah, these are I think oncology is certainly a model case for a whole lot of collusion, but I'm sure it occurs in other chronic diseases as well, and other devastating neurological diseases and things like that. I noticed that there's a question in the chat group about social pressure in decision making. Perhaps the panelists would like to try to address that. I'm not sure I fully understand, Dr. Bina, what social pressure means, but is it really that you ask a lot of friends and they give you different answers about what to do?
So there is, Dr. Nikhil.
Yeah. What I think Dr. Prabhat means is mainly for ending the treatment or stopping the treatment when the patient is terminal and in that stage. Because again, there are a lot of aspects. If we come to Indian patients, there are more. One is a financial aspect is there, because when the patient is in that condition, the treatment expenses are too much high, and generally it is a parent who is the patient, and son or daughter is the person who is in charge, and they have a huge pressure. Okay, they couldn't spend for their parents and they stopped the treatment, or they could have done more but they didn't do enough. And same again for the parents also. If a patient is their son or a daughter, then there is a social pressure that you didn't do enough, and how could you ask the doctors to stop the treatment? So that is there. I mean, that I have seen with so many people, and maybe Dr. Beena can also say on that.
I suppose it's not just self-induced guilt at not having been able to go all the way and do everything possible, but also the guilt that comes from your family and extended friends and relatives who are judging you for not having done as much as you should also. So I guess that's what they mean by this lo kya kahenge, like what will the world think of me for not having taken care right till the end, done everything I could possibly have done.
Yeah, and just following this session, actually, we have a group of social scientists, sociologists, and psychiatrists. They are all there in the session, and I would like someone to comment on this aspect, the decision making which happens. If someone wants to join in, that's completely, because I think they must have missed the initial bit of the conversation. So,
yeah, no. What I feel is, here. If you have a good palliative care team, when you're putting a oncology diagnosis, explaining to the patient and say, right, this is terminal, and there is not much that can be done. You sit with the patient, you sit with the family, and I think more than saying this is not we will do, if we say, right, this is the treatment option available now, we'll try to make the patient comfortable, pain-free, so that the patient can pass away peacefully with all the family members around, and having enough time, what shall I say, not be very unwell at the really end of the life, because their pain is controlled. You're trying to keep them comfortable. I think if you put it across to the family that you are doing something, you're doing a lot, you're making sure that the patient is passing away peacefully and not in pain in the hospital with all this treatment going on. You're actually, by it's not that you're not doing the chemo or the radio or anything, you're actually giving pain relief, you're making the patient comfortable. That might empower family to feel that they're not stopping treatment, they're actually doing what is best for the patient or the parent at that time.
I see we've run out of time, but do we have time to take Dr. Nikhil's question?
yes, please go ahead.
Okay.
Yeah, again about the social aspect only, I want to add a thing. 2 weeks back, I was talking to a doctor colleague only. His parents had some psychological issues, and they were not able to take care properly at home because of the lack of time and lack of experience in dealing with that thing. So he shifted his parents to a hospice kind of care facility, because the parents could get much better care, and as well as they could save on the cost compared to if they were in the hospital. So he did the right thing, but that is very rare, at least here in India, because there is a lot of social judgment. And I mean, because this is not the terminal case where the patient is dying or is in that condition, but patient is not dying, but they are not in that condition, you can take care of them at home, because that taking care of such a patient is a totally different thing. We don't have experience. So yeah, he was like, yes, I have been getting criticism from a lot of people, but I know that is the good thing for my parents as well as for my family. So that is very much there. Log kya kahenge?
No, I mean now I understand it better. But I think one key role that we can play is to how to empower them to answer those questions better. Give them the ammunition to say, you did the right thing, and you've taken all the right steps for this particular illness. But yeah. Okay, well, thank you all. Beena, over to you.
Thank you, Anand, and thank you, Shweta, Asha, and Nikhil. Stay back for some time because we had a really interesting session.